side at 100 and something. Nice, cool. That's great. So yeah, thanks for making it. You are here. You are here for the Austin Blockchain Collective monthly community meetup, which this month is about blockchain in healthcare. If you think you're here for agile programming, that's another room somewhere here. But this is the blockchain one, which is far more interesting. My name's Pete Harris. I'm executive director of the Austin Blockchain Collective. I see lots of familiar faces, so you know that. Just show of hands, who here? This is their first meetup of this. Wow, that's good. Welcome. So that's good because the next couple of slides are relevant then. So I always like to say at the beginning of this that if you leave tonight with just one piece of information, and hopefully you'll get lots of information from the speakers, but if you go away with just one item of information, it's the website of our collective. Because if you go to that, you can find everything that you need to know about the collective, or you can get links to everything that you need to know. So there's a lot of information there on the website, a list of all the companies, all the meetups. There's an education portal with links to lots of great education articles, and there are links to our blog, links to our Twitter feed, links to our LinkedIn group. So they are all worth looking at, and our blog every Monday contains a kind of a community news blog which tells you what's kind of going on with the collective. So I'd highly encourage you to go and check out the website. What is the Austin Blockchain Collective? Quite simply, it's here to put Austin on the global blockchain map, and we think it should be on the global blockchain map because there are probably about 120 companies in Austin in the blockchain and crypto space. So we think it's a pretty good group of companies, and there are more forming here every week. There are companies who are existing companies getting into blockchain, and there's even companies actually moving here. So, I was chatting last week to a company that may be setting up a development operation here. So, definitely a great, vibrant community here. So, what the collective is about, we've got a pretty simple kind of mission statement right now. It's probably going to expand a bit because we've realised that we're doing so many things. But right now we say that we advocate for, we showcase, and we nurture blockchain and crypto innovation in Austin. So we do help companies get better known. We help them collaborate with one another, and we kind of help them in their business. And we think that's a good idea. We think that by helping the companies, that will mean that Austin itself grows along with them. So it's kind of a bottom-up approach rather than a top-down version, but we're pretty comfortable with that way of doing things. So any company in Austin that's got a presence in Austin and is involved with blockchain or cryptocurrency technology can be a member of the collective. Cost no money at all. You just tell me that you exist and I add your name to our website, essentially. But thankfully, a few companies out there want to do a bit more than that and want to provide either some direct funding or some in-kind support. And because of those, we can actually spend quite a lot of our time providing services and sort of involved in the community. So these are the current companies that we have who are contributing to the collective. We're always looking for more companies, but very happy to have this group. And this group is slowly but surely growing as well. So very happy to to see that happening. One company that I'll just mention very quickly is Capital Factory. We're here in their space right now. They've been a great partner of ours. We've been holding our meetup here for about 2 years now, every month. Quite a few other meetups in the blockchain space here at Capital Factory, the Hyperledger one, the Ethereum group, the new Hedera group. So they've been very open and helpful to really nurturing the blockchain ecosystem here. And actually, we've begun to work with them outside of just having meetups here. We spend quite a lot of time here helping some of the member companies and partners get more involved in blockchain. So it really is becoming quite a useful partnership. So thanks to Capital Factory for that. So quick word about what's coming up. Next meetup is September 16th. Our meetups always happen on the third Monday of every month, and September 16 is really a showcase of new blockchain companies. So if you are involved with the startup in the blockchain space and you are no more than about a year old in terms of operating, I'd love to know about you, because we can consider you to be part of this showcase. We've got a couple that we're pretty sure will be involved, but would love to hear from all of you. We've got an October showcase, October meetup, which we believe will be about security tokens, and we've got a November meetup, which will be a preview of some of the sessions being presented at South by Southwest, and we'll have a South by person here who's really putting all the blockchain programming together, coming and talking about that. Couple of other quick diary dates. UT is holding their Texas Blockchain Summit on September 14th. They've got a great lineup there. It's actually a Saturday, so you don't have to worry about working. You can go in there, spend a Saturday and learn about blockchain. Tickets are just $100. There'll be an expo there, and there'll be speakers there from UT, from IBM, from Dell, the computer company, from quite a number of startups in the Austin blockchain space as well. So that will be a great event to go to. And about a week or so after that is going to be Austin Startup Week, which is a series of events mainly centered around Capital Factory. They've got several days of programming of different subjects, and on Monday the 23rd will be a blockchain track which the collective is curating. Officially the submissions for that day are closed. They closed last week, but if anyone here has an idea for a session, talk to me afterwards, because I can probably, assuming it sounds a good session, I can probably help get that on the program. So, but Monday will be the blockchain track, 23rd, and they have this thing called the Startup Crawl, which is a sort of big expo here at Capital Factory and around town. If you're a company that has especially a product which is for consumers, or if you just want to get visibility to the Austin kind of startup scene, or if you want to hire people, it might be a good opportunity and venue, an outlet for you to be part of. You can basically rent a table at something like $300, and they'll do a lot of publicity around it. So that could be a good opportunity too. AustinStartupWeek.com is the URL to go to there. So they're just some of the things coming up. Quick word of tonight's agenda. It's mostly a healthcare focused event. We'll start in a few minutes with a quick introduction to something called the Healthcare Working Group, which we kicked off pretty recently, working between the collective and some of our members in Dell Medical School. And we'll have Aman and Anjum, who are running that group, to introduce it. We'll have a quick showcase of, I think, 3 lightning presentations from local companies. And then there'll be a panel of medical practitioners really discussing how they see blockchain being useful for them. And then there'll be a good opportunity for a discussion after that. So that's the main meat of the evening. We always just start the evening, however, with shout outs from the audience. So this is your opportunity to just shout out, put your hand out. I'll be with you with a microphone, and this could be a new company you're forming, a new product you've got. You may be looking for a job. You may be looking to hire someone. All those things are useful and worthy things to shout out about. So do use the microphone, because we're live streaming this and recording it. So I'd like to capture all that you've got to say. Who's got something to say? Also, South by Southwest panels that you're involved with coming up. That would be a good thing to do a shout out on. Oh, okay, got one at the back.
Hey, good evening. My name's Al White. I'm the organizer for the Hedera Hashgraph meetup. Hedera Hashgraph is an alternative to blockchain, very similar distributed ledger technology. Our next meetup is 19 September, because there's nothing much else going on in September, so we figured we'd jam one more meetup in there. But we're going to be talking a little bit about the open access, the public release of the Hedera network. And we also have a developer that's going to walk us through some tool chain examples. So that's what's going on the 19th. Meetup is downstairs on the first floor in Johnny 5. Thank you.
Right. And Hedera is the technology, I believe, that Intiva uses, which they'll be speaking shortly. Hey.
Hey everybody, my name's Yolanda Baker, and I'm part of the New Chip Accelerator program, and I'm almost done with it. I would like to ask you a favor. I submitted my panel picker. The name is Curative Finance. Take a look at it when you can, and if you're interested, please vote for me. Thank you.
Great. And in fact, on the Collective's blog, there is a blog post which lists all of the South by sessions, all the blockchain sessions that I know about that are blockchain oriented, including yours, Yolanda. So if you want to find all the sessions to vote up, that's where you go to. And I'd also love you to vote up the one that I'm on too. There's actually quite a few from the Austin community. Any more shout outs from anyone? Oh, Paul. Hello. How are you?
I'm fine. How are you?
Didn't you guys launch something?
Yes,
Yeah. You want to talk about that?
Yeah, I will.
Okay.
Okay, a couple of things. The Austin Bitcoin meetup does meet every Tuesday up at the Baby A's in the Arboretum. The other thing was that we launched on top of Factom the PegNet, which is 32 stable assets running in an open source, open protocol. No ICO, no STO, no EIO involved. And there you go. Thank you.
Great.
There's one more in the back, Pete.
Is that sorry? Oh, yeah, sorry.
Hey, I'm Parker, and I'm with Kraken, and we're hiring a bunch of devs and non-devs. So if you would like to work at a large exchange, come talk to me.
Great. Super. Any more shout outs, or are we going to get going with the main one final one?
Verena Kahlo of Dell Medical School. I just wanted to announce real quick, we have a health learning series that is happening typically the third Thursday of every month. This month in September, in August, sorry, we're not quite that far along, we have Emma Cartmill talking about venture capital and health IT. It's happening Thursday, August 29th at 3 p.m. in the afternoon. If you're interested, let me know. I'll point you in the right direction where to find more info.
Hey, we have a few people that are listening online. Could she tell us where it's located and any information about parking that might be helpful? Because we have people online, they wouldn't be able to catch you afterwards.
Okay, sure. It's going to be at Dell Medical School in the Health Discovery Building in the big auditorium. Parking is going to be available in the Health Center garage right on the corner of 15th Street and Trinity, or along the street. If you can catch a scooter, that may not be a bad idea either.
Great. Okay. Any more? Okay. Good. Let's move on to the main program then. The good thing about this is I sort of don't have to speak from this point onwards. Going to hand over to Aman Quadri and to Dr. Anjem Khurshid, who are the joint chairs of the healthcare working group. They're going to spend a few minutes introducing the working group, what it's about, what their role is, and what its mission is. And then following that, Aman will, if you like, be the MC for the lightning presentations, and Anjem will be the moderator for the panel. So over to you both. I'll
Thank you.
give you both the mic. You can carry
My
on.
friend. Okay. Good afternoon, everyone. Thank you for being here. So the healthcare working group actually, we started meeting almost more than a year ago, on a regular basis, on and off for various things, because we saw some synergy in kind of the innovation that DelMed was established to do in healthcare, especially with new technologies and data, and what the Austin Blockchain Collective was destined to do. I think one of the key synergies was to try to see how we could build Austin as a hub for innovation in blockchain technology, especially in healthcare, which seemed like an area where there was a lot of potential, but at the same time, enough, I think, education had not been done, and enough, I think, successful experiments had not been done. So we thought it would be a great idea. And so as we were meeting together, I think we also realized that there is enough interest in companies and enough of an opportunity to do something more formal that can create deeper and more meaningful collaborations between the industry and an academic medical center, and through our center for the whole university. So we created the healthcare working group more as a platform that allows us then to engage faculty and students from the university, as well as engage companies from Austin, to start thinking about some problems together, and also to start thinking about what are avenues in which we can promote and expand the use of blockchain in healthcare. So we have been, I think we have some members who have been coming regularly, but we have also now seen a lot of interest from faculty and students. And with a raise of hand, can I see how many people are here from UT Austin? Yeah, that's a sizable, good, thank you. It would have been embarrassing if only one hand had come on.
You were the only one here, that would have been tough.
Anyway, I had a few people, so I thought at least there'll be more than one, which is good. And I think it's a new location for a lot of people from UT to get engaged in. So we're really looking forward to the kind of collaboration. Come on.
What he said is perfect. But in the end, the main goal for the healthcare working group is to do something that isn't done normally, which is private-public partnerships, right? So that we come together and we work on what the problems are in Austin from a healthcare perspective, from working with the, let's say, the state and even local governments, and solve a problem. Like I know last year I was not involved as in the healthcare working group. I was working on other projects, but like the MyPass initiative, which was around utilizing identity solutions for the homeless population. And so not only do we want to still continue to expand upon that, but we want to work with organizations that want to bring a couple of use cases to us and want to work with a prime organization like Dell Medical School with the faculty there and create a product or a solution that could then be brought out and be a model not only for Austin but for other cities beyond that. So that's really what our big crux of the thing, what we're trying to do.
And people who have worked in health IT know that entry into the healthcare industry is not as easy as many other industries. So understanding the industry itself of healthcare industry, I think partnership with DelMed gives a lot of benefit and competitive advantage to a lot of companies to be able to have partners who understand the industry really well and are also part of an organization, the Dell Medical School, which has been built for innovation in healthcare. So our logo is about rethinking health, and what better place to start thinking about rethinking health when you're thinking of disruptive technologies like blockchain.
Yeah, absolutely. Well, thank you. I think that's our announcement there, and I'm going to lead us into the lightning round. All right, so heckling is allowed. I'm just letting you know that. No, I'm just kidding. I'm just getting on that. We've got to make it interesting. So the first company that's coming up is Jeffrey Eystone from Cognitive Scale. Jeff was telling me, see, I pull people out. If you tell me something, it's done. But he was telling me, he's like, well, we're not truly blockchain, but we have to understand that blockchain to me and our organization says blockchain and emerging tech. And so we believe AI and ML and all these solutions can all work together in different solution patterns for healthcare and beyond. And so I'm going to let Jeffrey start. You didn't have any slides or anything like that? Okay, he's all off the cuff, all right? So we're going to go with that, and I'll leave it to him and give you about 5 minutes or
less.
Less? All right.
Yeah, less. Super lightning round.
All right, that's all right. Super.
And heckling would be great. Lighten it up a bit. I'm Jeff Eystone. I'm with Cognitive Scale. You're definitely saying, what's an AI company doing here in blockchain, part of the work group, that sort of thing. Our company has close ties with the community, the university. Our founders, technologists come out of UT. They come out of the IBM Watson Labs, that sort of thing, all here in the community. I think we had, out of 24 interns this summer, at least half were from UT, which was great. Awesome program this summer with our interns. We've got some where we start to touch on blockchain a bit, even locally with a couple big clients in Dell and USAA. We do things like personalization AI use cases around member profiles. And then when you get to things, customer profiles, customer 360, deriving insights for those sorts of AI use cases. When you get to healthcare and my interest in the work group, and especially these public-private collaborations, I'll elaborate on a bit of the use cases we get exposure to. But in the case of, say, patient profiles, member profiles, provider profiles, our large healthcare clients are people like chief digital officers. They're looking to transform the healthcare experience from patient records, like you could speak to social determinants of health, to national provider registries. And blockchain is just a foundational element of all of these sorts of initiatives. So we've said this how many times today, data, intake, interpretation to insights. We as a company care a lot about those foundational elements. So happy to be a part of the collaborative as a company, happy personally to be a part of the healthcare initiatives, and hoping just to help the work group get to some real MVPs, POCs, whatever it takes to collaborate. And our interest eventually is in the analytics, the insights, even things like trusted AI. And blockchain's a significant enabler of those sorts of technologies. So we'd love to help with any of these early efforts, from data collection, use, ownership, rights, all the way to analytics, AI insights, and trusted AI. That's the Cognitive Scale story a bit, and why we're involved here.
That's called lightning round. Right?
Lightning,
right?
right?
I appreciate it.
3 minutes, right?
That's good. I appreciate that. And the great thing about it is, so Cognitive Scale is a part as a sponsor of the Healthcare Working Group, or Awesome Blockchain Collective, as are we at AmChart. And so now Jeffrey and I are already talking about, hey, how can we combine forces and work on a project together? So you can be within the collective, you can be within the Healthcare Working Group and working on other projects because you're exposed to somebody you may not know, right? And so it's another great avenue of being involved with this. So next up is Mr. Paul Snow. Oh, you got to put that cell phone down, my friend. Come on up here. Always busy. Always busy.
Yes.
That's all right. You see, with Paul, we actually had to go through his wife to get him scheduled to be here. So, right?
That is true.
That's right.
Well, we just launched something, so constant support of people coming on with minors and such. So forgive me for being on my cell phone. I really apologize. Well, I'm here to talk a little bit about, or at least just give a slight introduction to what the blockchain can do about medical records. And this is based off some work that we did for the Bill and Melinda Gates Foundation in South Africa. And the idea is to use the blockchain to ensure that doctors and medical professionals have all the documentation they need when they're treating a patient, even in a healthcare system that's chaotic, and working to support migrant populations in many cases, as well as very unsophisticated patients. And so the idea with the blockchain was to create a system of cryptographic proofs that underlie the medical records that a client generates over the course of treatment, as well as billing information, as well as prescription information, as well as appointments and calendars and everything else involved in medical care. The people we were working with in South Africa recognize 6 categories of information when it comes to a patient. And here's the trick. How do I ensure that the doctor sees all the medical records that they need to see in order to treat the patient, but not expose the billing information or necessarily even the past calendar information or any other information in the medical file for a patient that has nothing to do with treatment? Furthermore, if I go to the billing office, how do I ensure that billing information is provided but not the medical records? And if I go to the scheduler, how do I provide scheduling information and scheduling needs and lab needs without exposing them to prescription medicines and other information that's not involved in scheduling appointments? And so what the blockchain does is it allows us to create small sets of cryptographically provable records that are tied to each other. But if you understand anything about the blockchain, you know that we use hashes, and it's the series of hashes that ensure that I have all the data. Well, there is a concept of salts, and salts are numbers that aren't part of the records, but you introduce them in order to create a hash that can't be reproduced by somebody else without those salts. And so what we created was a library. Think of the salts, nothing, even if you don't understand hashing and everything else, think of them as keys. And it's a set of keys that allow you to unlock particular records for particular needs, for particular purposes in the course of treating the patients. And here is the real kicker. If the salts are in the control of the patient, either through an account with a party that they trust or on their mobile phones or their mobile devices, and assuming that the doctors don't store those salts when they collect the data while treating the patient, once they've turned off their systems, there is no evidence left of what records belong to that patient. The medical records become anonymized because in order for me to interpret the records, I have to have the hash matched to a salted hash inside of the blockchain. So the real picture, I know, I went through a bunch of technical stuff. All this is technically correct, but let me give you a mental image. You have a fishbowl of beads, and you got a set of strings. And the strings belong to the patient. And the patient gives you the blue string, which is your billing information. They can loop up all the blue beads, and they can know exactly what information they need. But when they turn their system off, the string disappears, and you now have beads in a fishbowl again. And so your anonymity in the system is guaranteed because you can't string the records together unless you have the keys that the patient controls. And so this is the mechanism that you're going to see medical records being used. This is how we're going to control medical records in the future. We have the ability to distribute those medical records as beads without compromising the patient's confidentiality. They can still be encrypted and everything like we do today. But if somebody breaks into the system, they don't have an organization to figure out what your medical records are. And if you are being treated for HIV or you're being treated for hepatitis, you don't necessarily want everyone into your business. Your medical conditions and your treatment and your concerns are your personal, private information, and it's something that you need to give your doctors, but you don't want it just plain in a database for anyone to harvest if they break into the system. And that's what we were doing with the blockchain. And by the way, the last thing here, you're talking about a very distributed and sometimes disrupted system. So it was very critical in South Africa that we push those medical records, by a set of hashes, having a way of querying it and getting all the data that we needed, even if the patient showed up at a different clinic. How many of you are confident if you went into the doctor's office today, your doctor within a short period of time, like within an office visit, would have all the records of your entire history that are relevant to your treatment? How many of you believe those records are available? Okay, we have to be able to make it available to the doctor for you to get the care you need. We have to be able to secure it so that your privacy is not compromised. And that's what the blockchain can do for you. Thank you.
Thank you, Paul. All right, last up is going to be John Pittman of Intiva Health. There we go. All right, yeah, there you go.
Thank you.
No problem. Hey, lost it. Let's go back. There we go.
Good evening. My name is John Pittman with Intiva Health. Basically at Intiva Health, what we do is we have created what we do now. Is we've created a platform for credentialing for any licensed medical professional, meaning not only physicians, but anybody that's basically forward-facing to a patient that would has some type of licensure needs that create a compliance issue. So early on, what we developed was it's two-pronged. What we did is we developed one side of it, which is a platform for the licensed medical professional or the LMP to be able to house and administer his or her credentials or his credentialing packet, his or her credentialing packet. That packet, we just recently have released on Hashgraph as part of our build. We released just recently our platform. So we're now working in anger, if you will, with blockchain or distributed ledger technology behind our solution. We also then knew we needed to optimize the administrator side or the facility side. Now, knowing that 52% of physicians, which kind of drive a lot of the other licensed practitioners or licensed medical providers, 52% still work in a practice that is 10 practitioners or under, or 10 physicians and under. So we knew that working with the smaller practices that would grow or get traction with practitioners, so especially in the practices, the practice managers, that they could manage and then upload the credentials for their practitioners. So it's a two-pronged effect that is growing our practitioner base. We also supply a learning management system, which is a nice dovetail into what we do. Obviously, continuing medical education, continuing education is a big need in terms of state level requirements for physicians and nurses, et cetera, to maintain licensure at the state level. Also, if you have, for instance, a facility that's a center of excellence, a lot of times they'll require more continuing education just to maintain credentials or maintain privileges at that particular facility. So really that's what we do, and what we're working on is more or less the utopia, I suppose, and that is what happens in credentialing. I think everybody's probably aware or somewhat aware that credentialing costs a lot of money because for a physician, the average physician, to get credentialed at a facility, at a hospital, is anywhere from 90 to 120 days. It costs hundreds of thousands of dollars, not only for that physician, but also the facility in lost revenue. So the thought is, the end game for us is to create, through DLT and this living document as a credentialing package, to create just a complete immediacy around the ability to credential and accept it as a hospital, a credentialing manager or coordinator at a hospital in their committee, to understand that the distributed ledger technology holds that document in truth, especially when you're looking at primary source verification. It has to be done over and over and over again. Once we establish that the provenance of that document and it's verified, that that doesn't have to be done over and over again. So that's ultimately where we're looking to go. Collaboration-wise, I think our challenge really is going to be moving into, I think, some of the larger enterprise. So getting some, I think, relationships with companies that are working with some of the larger systems, maybe payers. This is really going to be more geared to the facility, to the hospital side. Insurance or payers have developed kind of their own system. It's not in DLT. We're working toward that as well. So any kind of collaboration around payer systems and the compliance around their credentialing for physicians would be greatly appreciated. I think that's about it. Thanks for the time tonight. And if anybody has any questions, we'll be around tonight. So thank you.
Thank you, John. I think that leads us into Anjum, your panel.
Hey, Anjum, do you want your team up there with you?
Yeah, sure.
We have David back here, and then we'll have
Nick there.
Yep.
Oh, look at that. All right, so
Serious star power here.
is that, yeah, I know. You guys are
Thanks,
bringing the
David.
big guns. I appreciate it.
I think we'll just. This is the standing panel. So sure. Just go with that. So as we had mentioned, one important part of creating this healthcare working group was to be able to increase the collaboration and communication between the medical school, clinicians and healthcare leaders and industry leaders like yourselves, and create that dialogue where we could then create probably more innovative solutions by working together rather than trying to figure out what the other group is doing. So I'm really pleased that as we launch this working group, we are joined by two outstanding healthcare leaders from the medical school, because medicine thrives on good information. So we collect a lot of information, but we also need that information in a timely fashion. And previously, as physicians, we were interacting with patients, we had some paper records, but ever since we have been able to digitize these records, then we can do so much more with the data in terms of linkage of data, in terms of analysis, et cetera, to be able to provide better healthcare. And both Nick and David, who I'll let them introduce themselves briefly, I think just nationally are some of the leading minds in terms of using data and technology in medicine, both from a perspective of delivering care, also from research perspective, and then the third pillar.
Look what I
that
got
is,
for you.
Ooh,
All
right,
let's
okay,
try
great.
it. And David's not being
Thank you.
left out, that's for sure. You guys can come around to the front, or we can move this across the way a little bit. Perfect.
Okay,
Yeah,
great.
I don't want to move that right now. You guys want to come around to the front? Just come to the front.
Quick response. Excellent. So, yeah. So I think we are very fortunate to have both of them to be able to share their experiences in terms of, and this is not meant to be so much of a discussion of blockchain applications in healthcare as really laying the ground of what are the kind of challenges that healthcare leaders today are facing, and then how do they see some of these new technologies affecting them. So without further ado, I would let each one of you please introduce yourself, and then as you introduce yourself, also talk about some of the key challenges in your field that you are tackling at the Dell Medical School.
Well, thank you very much, Andrew, and thanks for you and the other organizers for inviting Dave and I to come. We are both practicing physicians. We both practice in the neuro field. I'm a neuroradiologist, and David's a neurologist. When Andrew first talked to me about this, he said, there's this meeting about blockchains, and we would like you to come and talk about blockchains in medicine. And I said, my total knowledge of blockchains in medicine was a New Yorker article about 6 months ago. And I said, it was a really neat article, but that's about all I know. He says, well, it's not really just about blockchain, but it's about, basically, as previously mentioned, new technology, computational technology in medicine. And he knows that I'm very interested. My research has related to digital image analysis and clinical decision support tools using so-called AI, ML. And in full disclosure, I have a small startup related in this area. So I have a keen interest in general in this area. So the way I could put the two together, blockchain and AI and ML, is with data. And as all the previous speakers noted, data is really critical to the practice of healthcare. When we're talking about healthcare and data, we're talking about medical data. So the first thing that always has to be remembered is that medical data belongs to the patient. That is very clear, and for those of us who practice ethically, that is a real cornerstone of our thinking about this data. The information, medical information about a patient belongs to the patient. And one way or another, that has to be dealt with. Now, the physical instantiation of the data related to that information, that is the medical record, actually belongs to the entity that collected it, the physician, the hospital, or wherever. But even though that is owned by the entity, it is still controlled by the patient. And this all has to come about because the idea of the value of that data is to help take care of that patient. That is the primary purpose of medical data, is to take better care of that patient. And as mentioned by the gentleman who'd been in South Africa, which I'm very fascinated by their experience there, that medical data is of greatest value to the physician if it's all there, one place and one time. And that is a big, big challenge. And interestingly, in Austin, we're faced with an interesting version of that. There's kind of two ways we might deal with it. Is we could go the monolithic route, which large regional healthcare providers, national and regional healthcare providers, and EMRs like Epic, they just aggregate it in one giant monolithic database. And that's made available to the physician when they take care of the patient. That is one solution. And I would say that affects probably between 25 and max 50% of the population of the United States. I came here from an institution that had one of those, and when I opened up a patient's record, it really was pretty much all there, and it was an eye-opener, and this is only about 4 years ago that that actually came to pass. And I actually thought I began to see some benefit from all of the electronics and computers in medicine. That's not the case in the Austin region. There is no dominant healthcare system, unified electronic medical record. And this is probably the biggest challenge and opportunity in Austin. I don't say it's good or bad, we're more like South Africa. And your medical records, if you're here, is going to reside, I will bet, in at least 4 different places in the city. And I'll bet that you would have a hard time getting your hand on your own medical record information from all of those places. This is where I think there is a real opportunity. I don't think we can impose a monolithic system, certainly not within 5 years in the EMR. And if you guys can figure out a way to take advantage of this technology to aggregate that data and effectively leave it in the patient's control, and that would just be a huge opportunity and boon to the practice in this region. Now, I'll finish by saying that has to do with the primary purpose of medical data is to take care of that patient and use his or her data to help them. Now, there's a large secondary use of medical data, which I suspect some of y'all are more interested in, and that's on the research side. Things change a little bit there, but you still have to remember that if you track it all the way back, that data originally belonged to the patient and has to be dealt with. The easiest way to get out from under that is to get consent. Take what I just said is incorrect. I said the easiest way to deal with that is to get out from under that and get patient's consent. That's probably the hardest way to do it. The other way is to anonymize it, de-identify it so that it cannot be associated with the patient. There are still rules and restrictions. Just as a comment, it's a lot harder to anonymize medical data than one might think. And the more data you have on a patient, the harder it is to anonymize it. Because the more information you have about the patient, the easier you can identify that patient with the data. And radiology, this has come into play. We realized this for a while, now it's being recognized. If the medical record data has a typical CT scan of the head or MRI scan of the head of that patient, we can reconstruct that image and you can match it to Facebook. That's the challenge. David.
So I'm a neurologist, and I wanted to give you 2 examples of the points that Nick, my colleague in neuroradiology, brought up just now. So just taking a quick poll of the audience, how many of you know someone in your family or friends who've had a stroke? Just raise your hand. Okay. How many of you, similar question for dementia? So you are representative of the population, which is that these are the 2 most common causes of cost to the economy, to the healthcare system, and out-of-pocket expenses. And it is the leading cause of either morbidity or mortality in the United States. So I wanted to get very specific and talk about specific patients, because that's the theme of what Nick just said. So if you think about it, if someone is with their family and has symptoms of a stroke, most communities have done a pretty good job of educating the public about calling 911. And that's when the conundrum starts. So when 911 comes and the ambulance arrives at the home, there's a certain delay in time from where the ambulance left to get to the home. Meanwhile, a fraction of 1 billion neurons are dying every minute in the brain as the stroke is evolving. This is because of a blood clot that is lodged in a blood vessel, cutting off the blood supply to the brain of that loved one who's your friend or your family. It's minutes. It's really going fast. And the ambulance gets there minutes. That's great. That's when the problem starts. Because there's a conundrum. It's a dilemma which is resolved with technology and research and a very practical solution. I'll just take you through it. So imagine that individual. Now the ambulance is driving and they have to go to a hospital. Well, okay, here's where the complication starts. If you go to a community hospital, which is closest, if it's the closest hospital, then you get to the hospital quickly, but that hospital may not be equipped to give the clot buster to dissolve the clot because it's not a primary stroke center. And it may not be equipped to bring a specialist in quickly and pull the clot out, which is a comprehensive stroke center. Different hospitals are certified in different ways, and they're located in different places. And so do you go to the primary stroke center to give the the clot buster? But what if most people who have a large clot, you also need to take it out with the catheter. So you should have gone to the comprehensive stroke center. There are fewer comprehensive stroke centers than there are primary stroke centers. So where do you go? If you go to the primary stroke center and get the clot buster medicine, that's great if it was small clots. If it was a big clot, didn't do much good. 5% chance that it was effective. Very high chance it was not effective. You have to get back in the ambulance. Meanwhile, fraction of a billion neurons are dying every minute. So this has huge implications in outcomes. The chance of disability at 90 days, at a year, at 2 years. So now the question is, where does the ambulance go? Well, let's take that specific example. Let's say there's somebody my age who has a history of atrial fibrillation, irregular heartbeat. Well, the chance it's a big clot is very high. If I knew that at the time, I would know to go to the comprehensive stroke. It's worth going the extra few miles because you know you're going to need that catheter. That one little fact immediately tilts the probabilities way over and tells the GPS of the ambulance where to go, and then affects the life of that person at 90 days, at 1 year. But right now, we do not have a system that binds together in real time key pieces of information that may not be known at the time of the emergency. And of course, people who are having a stroke generally don't give a good history for very good reasons. So we have a problem with this, and a cloud informatics system of the type that Nick is talking about would be the solution. It would optimize the network of where you're supposed to go. So the optimization of where to go depends on features of that individual. It's personalized. So when people talk about personalized medicine, it's very, very life-saving or threatening for individuals with specific factors that you need to know, which will guide where to go. And of course, we can't afford to make every hospital a comprehensive stroke center. There aren't enough specialists. There isn't enough wealth to actually fund it. So this is a very good example of where information is really priceless. It saves money. The information helps to guide and optimize treatment, which is exactly what people want. Everybody wants that, but we can't do it because we can't bind the information together. Another quick example is dementia, which I brought up earlier. Right now, we all know what the result of dementia is. It's not good, right? But the pathway through the dementia process, which many of us will experience over the course of our lifetime as we age, it's not the same for everyone. With identical twins will not all have the same degree of dementia or no dementia. There are factors that affect the likelihood of progression of dementia. And one of those are things that are extremely preventable. Dehydration, minor infections. So people have mild cognitive impairment at home. They're living at home. They're happy. They have their family around them. They're teetering, but they're doing well and they're reasonably happy. The chance that they're going to convert from mild cognitive impairment to dementia is dramatically increased by three things, really. One is dehydration. The other one is minor infections. And the other one is mixing up medications, because people with good memory mix up their medication, let alone people who have mild cognitive impairment. So the issue is technology off the shelf right now can actually detect those things early. And people in the field, in the emergency services, if they only knew who was vulnerable, if there was a way of detecting that someone's going down the wrong path, you can prevent the emergency room visit, you can prevent the delirium that sets in, and then the irreversible dementia that follows from that delirium. So detection of early minor medical problems in people who are vulnerable is another example of personalized medicine where knowledge is really information is another very good example. And these are extremely expensive and common problems. And the solutions are not that complicated. We don't need the fanciest machine learning algorithms to do this, but we do need a system that has three pillars. We need a data bank, a health bank, a health information bank. We need algorithms, a place where algorithms can quickly access them, and then we need a network system that allows people to collaborate and effectively make diagnoses. So I just want to give you those two examples of exactly the points that Nick just made.
Thank you very much. These are very interesting ideas. So one purpose of the healthcare working group is to kind of figure out how companies can interact with leaders like you who have these years of experience of what will work, what will not work, where it will work. And usually we have seen that there is a disconnect between what companies are pitching and what healthcare leaders need for improving their. In your experience, what are some of the ways in which that interaction can be improved, and some of the things that you have seen which will make it much more effective to see what that partnership looks like, especially when you have a group of companies that are really thinking of innovative ways of using data and analytics and other kinds of things?
Well, I think one of the most helpful things to do is to get your hands dirty. I think one of the biggest challenges that the computational sciences face coming into medicine is a limited knowledge of the domain, of the details of the practice of medicine. And some of those details came out in the disease processes that David was talking about. You really have to know, you have to identify a very specific problem that you're going to try to solve. And that means you really have to come into the healthcare environment to learn the details of what the real problem is, what we can do now, what we can't do. And that is very, very hard. You're not healthcare trained. There's no reason for you to healthcare train, so you don't speak our language. And we're not computer science people, and we don't know your language. So that's probably the hardest barrier to get across, is that we're just from two different cultures and backgrounds, and crossing that, getting across there is just no easy way around it. But learning what it is specifically that you're going to try to solve with your solution is, I think, probably the first critical step.
Yeah, I think again, in the spirit of giving you examples, to solve the problems we were just discussing, you need interprofessional teams, people with different expertise who are collaborating. And the historical model for healthcare, academic healthcare collaboration with industry has been, the most established one is pharma, where there's a trial and then a contract, and then the funding is given, and then an answer comes back. And so it's not really a collaboration. It's a this is what we want to test this drug, and then you have 2 years to test it. There are standard ways to do the trial. The kinds of problems that we're facing, the two examples I gave you, really requires real-time interactive collaboration in a live team. And to make it more complicated, it requires in situ collaboration in the laboratory, which is the healthcare system. The clinic and the hospital is the lab. That's where we're actually studying these things. The community, in the cases I gave you with the stroke and dementia, well, it extends into the community as well. And these are real patients. And we are studying them and trying to optimize healthcare. And the innovation is really iterative on a very frequent time scale. So in my view, the secret of a successful collaboration between academic medicine, I would really say patients, academic medicine, and industries is very much a team approach and a sort of a collaboratorium kind of structure, which there is precedence for this. Really, one of the pioneers in this was Bell Labs, where they brought the innovation into the creation of the transistor and so forth. In healthcare, it's been harder because there are more professions that have to be at the table, and the location of the discovery has to be in healthcare, not remote from healthcare. And so many times the difficulty is not getting the data, it's actually interpreting the data or the artifacts in the data. And so interacting on individual patients, groups of patients, what does that really mean? What is that signal? Is that EKG really right? That really makes a big difference. But if it's all archived data, then it leads to difficulties that are not efficient and don't lead to solutions as quickly.
So those are very helpful examples.
Mic's off. Sorry, it was already on. Oh, it's off. Oh, I couldn't hear you. Go ahead.
Yeah, sorry. There's probably a delay when I see the light and then, anyways. Since both of you lead domains in the Dell Medical School, diagnostic medicine, neurology, as you think of collaborating with the industry and your own roles in terms of building these services at the Dell Medical School, maybe if you could say a few words about what may be unique environment here in Austin and at Dell Med that people who are not directly involved with Dell Med may benefit from knowing, and your own kind of plans of how you build this enterprise in partnership with tech companies and the technology that is available in Austin.
Well, we're a new medical school. I think we're a new medical school, so that we are forced to consider doing things a little bit differently than the traditional medical schools. And so, for instance, I'm the chair of a department called Diagnostic Medicine, of which is the only one in the country that I know of, which is an amalgam of radiology pathology based upon the idea that we have a lot of diagnostic data and that there's some commonality there. So our dean likes to do things differently, likes to structure things differently. So we're not too afraid to talk and act a little bit differently than the others. The other is the emphasis on population health. Many of us have trained in traditional academic medical centers, which are very acute care, episodic care oriented towards the patients that come to us in our hospital or our clinic. And the emphasis at Dell on the community, and David's mentioned actually gathering data, healthcare data from out in the community, not just in the hospital. I think there is extraordinary opportunity there. And that, of course, deals with a whole nother world, from the political world to the social world, traffic control and things like this. So I think those are some of the opportunities that we've got here that are a little bit different.
Yeah, the other factor which attracted me personally to Austin was the fact that the medical school, not only is it new with all the points that Nick made, but also it is the first medical school in 50 years in the United States to be built at a tier 1 research university. And for me, and the kinds of problems I'm solving, as you can imagine, with the examples I gave you, my background is in engineering, physics, mathematics, and then I went into medicine. And so being on a campus where I can literally interact on a daily basis and have joint collaborations with folks in the computational and engineering realms on campus is a very powerful set of opportunities that would not occur at standalone campuses that are the norm. Most of the medical schools that are research academic medical centers, they are separate campuses, and they don't have the luxury of having an entire university. The second is the tradition in Austin of innovation being spawned with much of the wealth of Austin coming from innovations that did not seem obvious at the beginning, which meant to me that the population, there's a lot of citizen science here. The population itself in Austin seems very open to innovative ideas. And I've noticed that in the patient population, who are very, very interested when they come to clinic. They want to know, what studies do we have they can volunteer for? And as long as we are transparent with them about what we're doing, they are extremely not only interested, but they expect us to be innovating. And I find that extremely powerful. And I think that reflects the culture of Austin and the people of Austin and how the city, the historical roots of Austin, And that is something I have not seen at the 4 or 5 other places that I've trained and practiced.
Can I just add one quick, little minor detail? A unique opportunity here is, and Rena was here and spoke earlier about the Dell Colab space. It wasn't called that, but again, how do you get in the health system and in that environment? And Dell has this unique opportunity where you can rent a Carol. It's right upstairs from our offices. It's right down the hall from his office, and your company can rent a small office or rent a Carol. And that's a really good way to get yourself in the middle of an environment. We can help put you in contact with clinicians and other healthcare providers that might be of interest, and give you a place where you can regularly come in and see the thing at work. It's a pretty unique opportunity.
Yeah, Nick has done a great job. But do you want to add something to the collab concept?
Thank you very much for bringing up the Texas Health CoLab and the workspaces at Dell Medical School. So it's a co-working facility. We are working very closely with the companies in our space to shore up collaborations and connections to clinicians across campus. And it is part of health product innovation initiative across Dell Med, where we're really trying to build a health innovation ecosystem that brings people together, especially here in Austin, where people are coming from a variety of different backgrounds, and we're now trying to get into healthcare. We're trying to put Austin as a health innovation ecosystem on the map, and so we really want to be there to facilitate that, and the workspaces and many of the other programs that we have going on are certainly part of that. Thank you.
Any questions from the floor?
Do you want to run it? Yeah. All right. Yes. Thank you.
You mentioned the patient's control of their data being a cornerstone of any new information exchange system. How do you balance that with the real potential of patients, especially in the use cases you were describing, of being either unwilling or unable to give consent for their data to be used, like a stroke patient or a trauma patient?
Yeah, there are a number of innovative ways to do that protect their identity. So there are what's called HIPAA waivers. In fact, we've just gotten the two problems that I described to you that we're interested in. We have HIPAA waivers, so that we actually, as long as we do not report out to the public any information that allows identification, we are able to see identified data without informed consent. And we do that by convincing the ethics boards, which there are legal and community-based representation, that we have minimized any risk of a breach. And so there are now, there is a realization that we are depriving the public of health innovation by not developing mechanisms that allow us to gain access to data. As long as we protect people's identities and the risk is minimal, there are ways to do this. But it does require, as Nick said, it requires expertise and ways to avoid the inverse problem where you can see a CT scan and then figure out who that was, or like a fingerprint almost. We have to make sure that it's foolproof, and the burden is on us as innovators in health to convince the ethics boards that we are protecting those subjects and we are not putting them at risk.
So my question is more toward the working group. So are there any frameworks or services? Like, what are some of the thoughts that you have come up with bringing together, not necessarily blockchain, but blockchain, machine learning? Like, are there any services or any ideas that are in play right now toward a framework of some sort?
I'll just take it. You want to?
Oh, it doesn't matter. I mean, I guess I'll answer that. How about that? So one of the things that we're looking for in the healthcare working group, we just had our first meeting just recently, is talking about the use cases that we feel like that are out there. Something that you guys described up there around stroke would be a great use case that we would love to be involved in. The other thing that we've looked at are things like credentialing, the things like track and trace or pharmaceutical supply chain management. There are things that we're looking at around medical records. So all those things are in play for us, but we can't solve all those problems, right? So we are looking for those organizations like an Intiva or like Cognitive Scale or somebody that are doing pieces of it that we can put together with Dell Medical School and come across it. So if there's an idea that's in your head that you're thinking, hey, look, I think this would be a great use case, we'd love to hear about it. And if we can put a team together or 2 or 3 different use cases, we're happy to do that. Can I ask a question? Sorry, so since we're talking about this. So I know, Dr. Nick, you'd mentioned something about when you worked in the past in an Epic system, in a healthcare system, and you had great access to data. Well, that's, what I find is, and I worked in an Epic system too, right? So I find that when it's all there, it's there. But if you come from another disparate source, it's difficult to get that in there, right? And Judy Faulkner, who's, the founder of Epic, basically said that why would we ever give access to patients to their own records? They wouldn't know what to do with it, right? That was her own words, right? So to me, the place that we should be looking, and have you guys looked, is the Health Information Exchange, right? So if we took all 5 health information exchanges in Texas, we would cover every life basically in Texas, right? And we have one in Austin. Is that something that Dell Medical School has looked at, is partnering with ICC to get all that data from multi sources to do a project around stroke?
You bet, but I'm not going to answer this question other than saying I'm not pitching Epic.
No, I understand. If you pitched Epic, we wouldn't need to be friends anymore anyway. But I'm just kidding on that.
If you're in one of those systems and you're a patient there, you can see that, okay, having that data could really help.
Right, absolutely.
I'm going to talk to Anjum because Anjum's involved with the IG.
And answer your question. So yes, we do have a health information exchange, and the concept of health information exchanges was to make data freely flowable among different disparate databases, because we knew that EMRs were not talking to each other, just because of market mechanisms and also technology that they had used. So unfortunately, health information exchanges have not also been able to successfully capture all the information that is needed. So there are a few examples in the country where regions have created health information exchange truly in the form that you were describing. And in Texas, although we have 5, initially we started with 13 health information exchanges, they don't necessarily cover completely the population. And even in Austin, it's a very subset of the data that is available. So I think conceptually, that's another platform that can allow for common governance, for sharing rules, etc. But in terms of how we share those information, I think still has to be driven by a consumer demand, and also negotiating it between providers who are currently storing that data, which is kind of the challenge, I think. So part of thinking of new technologies is, this is something that we have been doing for the last 20, 25 years, trying to share data, because clinicians knew it way before they needed comprehensive data, right? So as soon as it was digitized, the expectation was that we will get that data very easily on our computers, laptops. It didn't happen that way. So now we are really thinking of what are other ways to disrupt the system, because there are players like Epic and other EMRs, etc., who are not playing well with other EMRs. So we are not getting the liquidity of data that we were expecting will happen with digitization. So I think what we want to test then, in partnership with the HIE as well, is how do we create Austin as a place where we can demonstrate how that data can be made liquid, and what would be the benefits of doing that. So the specific examples that David and Nick were just talking about, and others that we will be exploring, I think it's part of this healthcare working group, is being able to see how can we demonstrate that for the rest of the country to follow, because what we are seeing in Austin is actually very similar to what is happening in most of the communities across the country, where physicians are frustrated because they don't get access to that data, and patients are suffering because their data is not available where it is needed.
Yes.
Hi, when I've been making the case to people that blockchain has relevance for healthcare, healthcare IT, and for hospitals, I tend to cite the case of MedRec done by John Halamka at the Beth Deaconess Medical Center as a working, installed, blockchain-based electronic health record reconciliation system. So I cite that as the working prototype that's known by an individual with high credibility. Are there current working deployments of blockchain in hospitals or with regards to electronic health records that you could cite, up and running now that you might want to mention?
I have actually worked at the BI as well as the partner system, and the only thing that I know of that comes close is an NIH research resource, which is called PhysioNet, which has some features of what you're describing. And that has been a very powerful tool for innovation, where it has all three pillars, actually. It has open source data file structures. And that's in PhysioBank, and it's all human data. The Sleep Heart Health Study now is fully posted. Much of Framingham Heart is now in it. And the second pillar is Physio Toolkit, which is all of the open source algorithms and software needed to apply to those. And then the third one is Physio Network, which is the network collaboratorium for networking, so people in Hungary can collaborate with us and to innovate. That has been a very powerful tool for innovation. And the way that that's organized has similarities to what you're describing, but it's not, I guess it's technically not a blockchain, but it's very similar.
Any other questions? Do you have questions for them?
Oh, another question. So how do you go about anonymizing patient data for research? And as you mentioned, the more data you have, the more difficult it is to anonymize data. How do you solve that?
So it's important to distinguish anonymizing for the researcher. So for example, when I request the data, it doesn't need to be anonymized. I can see it as a clinician working in the system who has all the IRB oversight and expectations and responsibilities. So I can see the identity. But when I want to report it out to the world, I have to make sure that there is no way to go backwards into. There are many things that I have to do when I publish. When, for example, I mentioned PhysioNet, that is open source. Anybody can log on and look at enormous amounts of data, but these are presented in a way so that you can't, if it might have a single lead ECG, that you would have no way of knowing whose ECG that was.
I think I'm looking at it more from a data scientist's perspective. And as you mentioned earlier, eventually there's going to be a collaboration between different practitioners and scientists or engineers. So when more engineers are involved, I could foresee more data scientists involved with patient data. And that's the scenario I'm referring to with anonymization of patient data.
Right. So for both the projects, both of the problems I described to you as examples, the teams that we are assembling include engineers, scientists, some of whom are not employed by UT. But they still have to go through the ethics. They have to take the city exam. They have to attest. There's an ethical review of their involvement. There has to be an understanding that they're now within the collaborating team. So this, again, it has to do with who are doing, what does the team look like? It doesn't have to be a closed team of just clinicians.
And that's part of, I think, the collaboration that we are thinking of is, to your question of blockchain applications, as we have seen, there are actually very few practical implementations of blockchain in healthcare in the US. You know, a lot of the successful examples are international. And part of that is just because of the complex regulatory compliance needs in the US that we are talking about in terms of healthcare data. And so I think part of the work that we'll be doing here is not only looking at technological implementations,
but also looking at the legal, social, and other aspects of implementing blockchain solutions in healthcare that are informed by, again, industry standards and industry requirements on what will be successful in applications, right? So you can have a solution that says I can move data from this place to this place in this way, but when you actually come into play, then you have to integrate it into the clinical workflow and the business environment and the processes that are in place in healthcare, which are complex, not standardized in many cases. They vary from one organization to another. So being able to understand all those things is going to be very helpful. And that's what we want to improve and promote through these dialogues that we'll be creating. So I want to thank Nick and David for giving us great insights and for taking their time from very busy schedules. Let's give them a round of applause.
Okay, great. Thank you. And thank you to Aman and Anjum and the presenters. So it's the very much beginning of the journey here with the healthcare working group. Certainly an awful lot of work ahead of us, but I think we've got a great mixture of blockchain innovators, AI innovators, working with the medical establishment and the research establishment. So very, very excited about what that collaboration might bring. That's the end of the formal part of this evening. We'll certainly be able to carry on networking here in this room for another half an hour or so. We'll be able to go down, or if you want to go downstairs, get a drink in the bar, continue networking. Welcome to do that. Next meetup, September 16th, back here in this room. South by Southwest panel picker voting is carrying on all of this week. Please check out that blog post that I mentioned with all of the South by Southwest blockchain sessions involving locals, and please give them a vote. And remember, you can always find our blog from our website, austinblockchaincollective.com. So have a great rest of the summer. Hope it cools down a bit. See you back in September. Cheers. Bye.
Good, how are you? All right. Trying to make it make big. Yeah, they came out every